If you are pregnant or you've recently had a baby, this podcast is for you. I am your host, Kath Bequee, a physiotherapist working in women's health and mum of three. Inside my online program, Fitness Mama, I just love helping support women to care for their bodies during pregnancy, prepare their bodies for birth, and support their after-birth recovery, helping them feel confident and strong inside out during this important stage of their lives. In this podcast, join me each week as we dive into all things pregnancy care, childbirth, and postnatal recovery, helping you through every step of the journey. It is absolutely possible to feel amazing and confident in our bodies during this motherhood journey, and I want that for you. Come and say hi to me on Instagram at FitnessMama, and let's dive into today's episode. Hello and welcome back to the Pregnancy, Birth and Recovery podcast. Today I am discussing birth plans with an obstetrician, Dr Hugh Porter. So Dr Porter is a highly skilled obstetrician with a passion for both low and high risk pregnancies. Dr Porter is happy to provide natural births, waterbirths, Calmbirths, VBAC, so vaginal birth after caesarean section, elective caesarean sections, maternal assisted caesarean sections, inductions of labour, and twin birth, both vaginal and caesarean. And in today's episode, Dr Hugh Porter discusses what is a birth plan, how important it is to develop a birth plan. He discusses some different birthing options to consider and some things to consider in a birth plan. So we talk through fetal monitoring, vaginal and cervical exams. We talk through Forceps versus ventouse, emergency caesarean versus Forceps. We also discuss sharing your birth plan, like who to share it with, and as I mentioned, when things don't go according to plan. So I trust you're going to get a lot out of this episode. I thoroughly enjoyed talking with Hugh. He's got a very holistic approach to it all. He's very much comes from what I gathered from our conversation is he really does have the mum's best interest and the baby's best interest in mind at all times when making every single decision in conjunction with the mother. So it is a really great interview and I trust you're going to love it. Before I do dive into this episode, I would love to invite you to come and join us inside Fitness Mama. If you'd like to reclaim your pelvic floor, core and strength safely, if you'd like to care for your body during and after pregnancy, then all of this is available with Fitness Mama. Perhaps you found you're not exercising as much as you'd like to during pregnancy and after birth. Perhaps you're busy or you've lost the motivation or you're not sure how to best be looking after your body. Perhaps you've got the pelvic girdle pain and abdominal muscle separation and you're not sure about the best exercises for you. Or you'd like to get back into running after birth and you want the best kickstarter possible. Then Fitness Mama is for you. So join us for a free 7-day trial for these convenient, short, easy workouts that you can do from the comfort of your home whilst your bubba kicks around on the mat next to you, whilst your toddler runs around, or at the end of a long day at work. Head to fitnessmama.com and the link is in the show notes. Right, let's dive into this episode. Hugh, thank you so much for joining me today on the Pregnancy, Birth and Recovery podcast.
That's my pleasure. Thanks for having me.
We were just talking off air about how you've got a lady who's having a baby as we speak, 4 centimetres dilated. So we may have to stop this episode.
Yeah, if I get a call in the middle of it, we'll have to have a part B, but we should be pretty good. 4 centimetres, we'll be all right.
Absolutely. So we're discussing birth plans today. And it's great to get a doctor's perspective on this because from my experience, it's mostly, I guess, in the Instagram world, it's, midwives do a great job at childbirth educators talking through this. So to be able to talk you through a birth plan from your perspective is, it's great. So thank you. Let's start at the start. So we're all on the same page. What is a birth plan?
Yes, so I think it's a relatively new phenomenon. I mean, I can't speak for 20 or 30 years ago, but I think with the onset of all this social media and people with access to information these days, people's thoughts about how they're going to have their baby has really come into the forefront. I think people are starting to think about it in the lead up to their actual birth, about what they want and how they want to achieve, having a baby in the way they like. And I think there's a lot of information out there about things that can help in and being prepared for the birth rather than just kind of going in there and seeing what happens, I think can really help.
Being more, rather than the recipient of the birth, being more of a proactive player.
Yeah, that's right, exactly. And I guess sort of advocating for the kinds of things that you want when you're in the room having a baby. It's not just kind of being told what to do. It's having an idea of the things that are available to you, certainly. But it's also being educated about, historically, lots of things can happen in a birthing room, and I think there's been a real shift towards people being worried about medical intervention and all these kinds of things. But at the end of the day, a lot of those things do have a reason for them. A lot of things aren't done for no good reason. But I think people want to be educated, want to be informed about why are things happening. If we have to do a Forceps or a caesarean section, is it why? Are we just doing it because we've, got a game of golf booked for this afternoon and got to get out of here? Or is it because we're worried about your baby, So I think people, that sort of idea of advocacy and education is really important to people these days.
And from your perspective, do you find it's helpful for mums, the mums who do have a birth plan, do you find they have better outcomes or birth satisfaction than those who don't?
Yeah, it's a really good question. So I generally encourage my patients to antenatally, so while they're pregnant, to have a think about the kinds of things they want to achieve out of the birth itself. Now, everyone's different, right? And I have a really wide-ranging sort of subset of patients. And some patients just want to sort of come in and say, look, I trust you. You tell me what the best way to do it is. I want to have a happy, healthy baby, and that's it, okay? And then I've got other patients that come in that have done, read everything they can possibly read, and they have really sort of formed ideas about how they want it to be. I can't help but feel that having a bit of an idea about what you want is a good thing. So I really encourage my patients to get some antenatal education. There's a few different courses out there that people can do in the lead up to labour itself. And there's a few courses that I recommend. I'm not involved in any of those courses or anything like that. And a lot of the hospitals have them as in-house education programs. But there's also a lot of, say, midwives and things that run programs externally that I think are really good for all that kind of stuff. And it's the kind of situation where they can talk you through labour. They can talk you through what happens in the day leading up to it, at the onset of those sort of just a few tightenings and things, all the way through to someone's fully dilated, about to push out their baby, and just give them some tips and strategies for when things do change, because things change quickly in childbirth. So I think it is really important for people to have a bit of a plan going forward. At the end of the day, I sort of encourage my women you need some adaptability. You need to be able to say, hey, things can change and we may need to pivot to this plan or that plan. But I think it's nice to have sort of thought about the way you'd like it to go. And to your point, I think people do have better outcomes if they are trying to achieve something.
And I think what you mentioned there is really important, where when you're in the moment, there sometimes isn't much time to make a decision. So if you have that, even a base knowledge, some information about the different options available, it's better than making a decision in the heat of the moment when you've got to make a decision quickly.
The public system is notoriously difficult for this sometimes, because when I cover the birthing unit at the hospital that I work at, I often have never met the patient before. They're in labour. I'm just on for that day. And if something happens towards the end, suddenly the baby's heart rate's dropping, or, there's concern about the baby's welfare, I need to walk in and say hello and introduce myself to someone at probably the most vulnerable they've ever been in their whole life, and say, hi, I'm a doctor and I need to do X, Y, Z, be it I need to pop your legs up in stirrups, or I need to examine you, or I need to, put a forceps on your baby and help pull it out, that kind of thing. So it's very tricky. So I think antenatal education is so important for that, because having a bit of an idea of some of the things that can happen and may happen is really important. But I think, to my experience, the patients who come in with very, well-formed birth plans are also probably the kind of people who are looking for some real positivity and optimism about the birthing process. So it's a real catch-22. It's difficult to say to someone who's like, I want to go low intervention, all normal birth, I want really calm room and it's all positive energy. And then to somehow bring up, oh, by the way, I might need to put a pair of forceps on your baby or cut an episiotomy. And these words, they stick out to someone like that, like I don't want to hear that kind of that chat. So you've got to be very careful about how you introduce concepts without springing something on someone at the very last second. So the way I typically do that is to usually I encourage people, if they're going to have a strong birth plan, to have it formulated by around the sort of 34 to 36 week mark. So there's still a good month before the baby's due. It gives us time to review that plan together, because I think it's really important to show the plan to your obstetrician and say, hey, what do you think about all this stuff? Because sometimes I get things and I'm like, oh, that's may not work, or that can I talk to you about the reasons why I think that may not be the best plan for you. But it's really good then, because if I can see that plan at, say, 36 weeks, that's a good time for me to say, okay, why don't we talk about all the things that may not be on this document that may pop up? And that way, at 37, 38, 39, we've done all that, we've had the chat, we can go back to the positivity in the plan, which is the normal natural birth.
This episode is brought to you by Baby Bee, Australian-owned and designed prams combining quality, safety and style. Not only does Baby Bee let you try their prams at home with free returns for 9 months. Yes, that's 9 months. They also offer an industry-leading 3-year warranty for total peace of mind. With thousands of 5-star reviews, around-the-clock customer care, and up to $300 of free accessories with every pram, what are you waiting for? Go visit www.babybeeonline.com and check them out for yourself. And yes, for listeners of the podcast, there is a 20% discount code. Enter FITBEE, FITBEE 20 at checkout, and T's and C's apply. Yeah, I like that, because so what you're, and correct me if I'm wrong, but what you're suggesting is for women, let's say, for example, women who are really wanting, for various reasons, to have a natural birth, and they're wanting to go low intervention, as you mentioned. So you're mentioning talking about all the sticky situations where you might perhaps need instrumental delivery, or you might need to have a caesarean or pain relief, getting that out of the way so that then you can go back to talking about options for that all natural.
That's right, yeah. And it's funny, because I think almost in a way that the women who are very dedicated to a particular thing in labour are probably the highest risk of being disappointed. And that's kind of a hard concept to get across to someone, because they've put so much energy and importance on this exact thing happening. And therefore, the less we hit that exact thing, the more disappointed they can be. So I try really hard to discuss all the things they want, and to be able to say, look, if you don't achieve this, it's okay. Like, one of the things I find myself saying to my patients all the time is, be kind to yourself, because things change. The patient who would never have an epidural ever because it's an epidural, after 3 contractions, who says, oh my God, I need an epidural. It's like, that's okay. It's okay to do that, and be kind to yourself, and say, you don't put yourself on the hook and say, I have to achieve something,
And for those who do have a very, a definite plan where they're really not wanting intervention, are they, if they're putting off interventions done as the labour progresses, is there a chance that will end in more instrumental delivery, or like a caesarean? Like, is there a larger chance that... I'm not saying this very articulately, but I once spoke to someone who said the longer the birth plan, the longer the caesarean scar, meaning if it's left to the very last minute, they have to open up quickly and get the baby out because it's last minute. Would you What do you say to that?
Yeah. So like when someone comes to me, and I get it quite a lot. Someone will come in with a, we sort of joke about it sometimes, like a laminated birth plan. Like this is it. This is what we're doing. Okay. To me, the most important thing is to try and tease out the why. Because I think if you can address the why, then often those things then you have got a little bit of scope to change things around. And I think so much of it comes down to trust. And I think that the why often, the more rigid a birth plan is, I have to have this, I can't have an epidural, I have to be able to move, I want to be in the bath, all these kind of stuff. I think often, I often sort of say to patients, like, what is it about those things that's so important to you? And I think a lot of it comes down to, the two things I get is either fear, like it's really being worried that they're not going to be in control. I think that's a big one. And also trust. And I think, with so much social media stuff out there saying, that everyone just wants to intervene, this cascade of intervention, obstetric violence, obstetric trauma. I think people want to avoid that by taking control of the situation. And like, if I'm perfectly honest, I think obstetrics has probably got very paternalistic, at least sort of in the last 20 years, so far as I can see, where we've probably gone too far in this is the way you should do it. We're just going to do it this way. There's a lot of inductions, a lot of, unnecessary interventions and pulling out early and that kind of stuff. But it is like, by finding out from my patients like what it is and why they want to do certain things, we can often educate to say, okay, well, if you're worried that I'm just going to walk into the room and say you should have a Caesar without thinking about it, then why don't you let me explain now at 36 weeks the kind of reasons why I would come into the room and say, I think you should have a caesarean section. And if you can build a trust with the patient and they know that you're there aiming to achieve the same thing they are, because what they're really wanting, I think, is to just achieve a natural birth, right? That's what they want. It's not that I don't want to have this and I don't want to have that. It's just I just want to do it naturally, and safely. And therefore, if you can come in and say, look, we're both on the same page here. I want you to have a natural birth. And if you trust me, then I'm only going to use forceps or offer you a caesarean section or do any of those things, or an episiotomy, all those things. I'm only going to do those if I think you really, really need it. And that's, to my experience, that's what's helped with people with very rigid birth plans, is to just help get the trust. And then people are often willing to say, okay, I believe that you're not just here to intervene. You're not just here to get involved. I say to my patients all the time, the best birth is the one where I can literally sit in the corner of the room on my hands and just sit on my hands and let it all happen, because that's what should and often happens, right? Like, I don't want to come over and intervene in a birth. I don't want to get out of bed in the middle of the night, do a caesarean section. I don't want to get out of bed to, pop a pair of forceps on and cut an episiotomy. That's never in my plan for a birth. Okay. But where the insurance policy, that's what an obstetrician's there for, is to be able to say, hey, I'm worried about your baby and that kind of thing. But to your question of does it change outcomes? Certainly there are times where the more rigid someone is about something, the more challenging it is to get over the line to change the plan. And that's probably where we run into the concept, the concept of safety. And that's where I get challenged if I sort of thinking, look, I'm worried about your baby. I can see the heart rate's low. We need to be changing the plan. The more time we waste at that point, debating whether or not we should do something, I'm sort of thinking, oh God, the baby, So, and the hard part is balancing, like a birth plan is essentially for mum, right? That's it. The birth plan is about mum's experience. We've got the baby as well. And that's often not part of the birth plan, right? That you can separate the two, which is a really tricky concept. And everyone wants to have a healthy baby. There's no question about that, right? Sometimes you have to forego some of the things in the birth experience to have a healthy baby. If you, like you said, if you leave it too long, sure, you're going to have a natural birth. If we wait forever, your baby will come out eventually, but we also want the baby to come out and be in a great condition when it comes out. But I think, again, it just comes to so much back to that trust and communication, and the patient knowing that if we're sort of saying, hey, it's time that we change the plan a little bit, we're going to get a better outcome here.
Now, we might be going off topic, but while we're discussing this, I'd like to, and this is the pelvic floor physio coming out in me, I'd like to discuss a few different options that women might have and why we might choose one over the other. And as you said, baby needs to come first. So I'm sure that will come into the equation. But I'm also thinking about it from a pelvic floor perspective, where we know that ventouse is much kinder to the pelvic floor outcomes versus forceps. So if a labour isn't progressing, at what stage would you recommend ventouse, and at what stage would you have to say, okay, well, I'm making the assumption that you would choose ventouse over forceps. Is that right?
Yeah, look, it's a really good question. Okay, so I want to say the art of obstetrics for an obstetrician, right? You learn how to deliver a baby in the first 2 weeks of your training. And after that, you're honing your skills of what is the best way to manage mum and baby in the part where they're fully dilated for the rest of your career, right? That's it. And really that's the challenge is if I take a junior doctor, and I teach a lot of junior doctors about delivering babies and things like that, right? A pair of forceps, right, will go cradle baby's head, okay, and you can put a lot of force. You can physically pull quite hard on a baby with a pair of forceps. So in all honesty, you can almost pull a baby out of a pelvis with a pair of forceps under any circumstances, as long as there's no cervix left, as long as someone's fully dilated, right? The problem is sometimes you have to pull quite hard to do that, right? So if you're pulling a baby that's very, very stuck, that's where from the pelvic floor physio point of view, you're going to cause some real trauma, okay? A vacuum is good. A ventouse is, I like to think, is everyone's first option in childbirth. I would always do a vacuum if I could. The reason is the vacuum doesn't increase the circumference of the baby's head at all. It sits just on the top, okay? And when you're pulling on that, the baby's head is the thing that's fitting through the vagina. A pair of forceps actually increase the circumference of the baby's head and physically make the vagina stretch more. So we're physically stretching. We're more likely to tear. We're more likely to do sort of avulsions and things like that. But the problem is not every delivery is appropriate for a vacuum. And that's coming back to this art of obstetrics thing. When I do an examination on someone who's fully dilated and I need to deliver that baby, say there's fetal distress, say the baby's very unhappy, it needs to be delivered, it's way too late to do a caesarean section, the head's way too low, I need to decide what is the best instrument to help deliver this baby safely. And there's so much evidence to say that if you put a vacuum on and have a couple of pulls and the vacuum pops off a couple of times and then you put forceps on, the outcomes for that baby are way, way worse. So you need to be deciding as an obstetrician, if I need to deliver this baby safely, am I going to be successful with a vacuum delivery? Because you can't physically pull as hard with a vacuum. It's just a suction cup on the top, whereas the forceps really cradle the baby's head from behind. So sometimes a vacuum is literally not possible, okay? And that's the decision to be made. Now, going back to the other option, which is essentially if someone's been fully dilated for 2 hours, they've been pushing effectively and their head is still quite high, then sometimes you think, well, yes, sure, I could put a pair of forceps on and the baby's head's very, very high up in the pelvis and I could probably pull that baby down through the pelvis. But maybe at that point, it might not be in mum's best interest. Maybe a fully dilated caesarean section where we push the baby back up is a better option. And unfortunately, that's not always possible because the baby's head's very low and it's physically impossible to push the baby's head up. But sometimes in that situation, I probably favour that for someone who's been pushing for 2 hours. Going back to the birth plan thing, one of the things that's been coming up a lot that I've noticed in my patients is people have been giving me a lot of plans that we don't want examinations, essentially, right? So we check on the progress of labour by how dilated is the cervix, how high is the head. We're looking for signs that labour is progressing the whole time, which is why we do examinations in the first place. Now, I'm pretty relaxed about things. I like to let my patients, if they don't want to have examinations, sure. But when I'm teasing that out with my patients about when they have that in their birth plan, I say, look, how about we sort of come to a bit of a compromise here? There are certain points where I think an examination is really important. And one of those points is when you're fully dilated. So and I often say to patients, like I can see the point of the birth plan is you want to have a natural birth. Okay. If you start pushing on a cervix that's not fully dilated, the cervix will swell. And once that cervix is swollen, say you're 8 centimeters, you think you're fully dilated because of, and then you start pushing, suddenly you've got this really swollen cervix. You will almost certainly have a caesarean section. So that one is really not in your best interest if the plan is to have a natural birth. So I always think better to do a check to say, yes, great, we are fully dilated, right? And then we can start pushing. So in my experience, what I try to say to patients who want to have low intervention is that's one vaginal examination that's critically important. The other real benefit of that one is I can see how high the baby's head is and what position the baby's in. Because then if you've been pushing effectively for 2 hours and I assess you again 2 hours later, if their head hasn't moved, if you've been pushing for 2 hours, you'll know as a physio, you can't do any exercise like that for 2 hours. If you've been pushing effectively and you're putting all your energy into contraction, you should be absolutely exhausted after 2 hours. Like you just don't have any energy left. And if that head hasn't moved, then I'd be crazy to put a pair of forceps on and try and pull that baby through the pelvis. It's just not, that's not in anyone's best interest.
And I'd just love to ask you about that. What do you consider a long pushing phase? Is it 1.5 hours or 2 hours? Because I know with literature, it's a bit varied.
Yeah, really good question. Do you know what? I actually don't think there is a time is not a good way of doing it. If it depends on contractions. So if you think someone could be contracting 2 contractions in 10 minutes, or they could be contracting 5 contractions in 10 minutes. So the difference between of half an hour, right? In your example of 1.5 hours to 2 hours, if someone's only having 2 contractions every 10 minutes, in that extra half an hour, they only get 6 more pushes. If they're in that half an hour, if they're contracting 5 times in 10 minutes, then they're getting, 15 pushes. Is that right? I don't know math. But you know my point? So actually, rather than a time thing, I'm much more interested in how many contractions are we having? But more than that, how effective are they? I'd prefer someone to push for an hour and put every bit of energy they can into it for an hour, and do really effective pushing, than for someone to do sort of half effort for 3 hours or ineffective pushing for 3 hours. Because to be this is, people often say, they haven't had enough time. And my point is, if you get to 2 hours and you can still push, then maybe the pushing hasn't been as effective as it could have been. That's why I think coaching and guided pushing is really important, especially early on. So what I say to my patients is look, if you don't want examinations, that's fine. I'm just here to help you do whatever you want to do. But if I work with you for a couple of pushes at the very start, especially for someone with, say, an epidural or something like that, and make sure that the energy you're putting down into your uterus and into your pelvis is effective, you're going to push so well for 2 hours. But if you just if you're just blowing out all the energy and nothing's really happening, 2 hours later you're tired, there's been no progress. Sure, you could go another 2 hours, but probably not going to change the outcome. So I think that the answer is, for me, is effective pushing for as long as you can.
Yeah. And I think it's tricky when it comes to research, isn't it? How do you research that? But
you can't research.
Yeah. But we do know with what little research there is, but the longer the pushing phase, so between 1.5 to 2 hours cut off, depending on what you're reading, that's also associated with worse pelvic floor outcomes considerably. So that
doesn't surprise me too. So as a rule of thumb, I would typically say for someone who's never pushed before, if they have an epidural, just as a very rule of thumb thing, if they've got an epidural block and the head's not really low, I typically say, why don't you have an hour of what we call passive descent and let the head just come down passively without any active energy on top. And that gets it as low as it'll possibly get before you start pushing, okay, to save some energy. So that's an hour of passive descent. For someone who doesn't have an epidural, I often say, look, is there any point, you've got good sensation, maybe not. But if people want to do it, that's fine. And this is all assuming baby's happy too, right? So we're monitoring the baby either with intermittent monitoring or with a CTG, and we know the baby's happy, there's no problems. Once someone starts pushing, I would say for a primip, so someone who's never had a baby before, I'd say usually I give it about 2 hours, okay, of effective pushing to say, have we had a baby by that time? For someone who is a multip, like a multiparous person who's had a baby before, usually I like to think, potentially if you're pushing well, you can push a baby out in about an hour, okay? But these, as I say, these are so independent. It's the difference between, I think, from my point of view, private and public care. I don't know the patients. I'm generally not involved in the fully dilated stage in the public system. So I come in at 2 hours. I haven't seen what they've been doing. I listen to the midwives and they say, this is how the patient's been pushing. I examine the patient, see how they're pushing. But it's very hard if I haven't done the initial examination to compare to the final examination, because if you've still got energy and the head's moved down and you're 2 hours later, sure, have more time. If you've still got energy, go for it. But if you're exhausted, I think we've all been to the gym and lifted up, a heavy weight, and you can do 8 reps really well. By the time you get to 10, you're getting pretty tired. Try and do 12. You can't even lift the thing off the floor. So if that's sort of the equivalent at the 2 hour mark, if you've already done your 12 reps and I'm saying, okay, well, now we need to push for another half an hour, it's like trying to lift those weights up again off the floor. It's really, and that's when potentially someone needs help with the delivery at the end. But there's also that thing in the back of your head saying, why, if someone's pushed effectively for 2 hours, why hasn't this baby come out? Most people will have had a baby in that time. Is there a malposition? Is the baby posterior? Is there CPD? Is there a problem with the way the baby's fitting through the pelvis? Have we got the energy? Are we having enough contractions? Like I said, if we're only 1 contraction every 10 minutes, then we've only had 6 contractions in an hour. So yeah, there's a lot to take into that.
Not simple.
Not simple, yeah.
I think you've answered all my questions, Hugh. I was really wanting to discuss when things weren't progressing, what are the options? You've done that. We've talked about emergency caesarean versus forceps. We've talked about exams.
I think the one thing I probably would say is, and just to bring up sort of one thing, when we talk about birth plans, I guess there's a lot of things that a lot of common themes that I'm seeing in birth plans sort of at the moment, and there's often people tend to be splitting them into the first stage, second stage, so early labor, like things they can do in that stage. Some of the stuff I really love seeing in those birth plans is this sort of positivity. I can see from a birth plan, it's like we want positive energy in the room. We want, people to come in less kind of talking about things, just, making conversation and that kind of thing, dimming the lights, having a nice calm music, having the right support people in the room, all that kind of stuff. I love seeing that stuff in a birth plan because that tells me that someone's really wanting to be in the moment. And we know from the research that stuff really helps. We know continuity of care. We know having a supportive person, be it a doula or a midwife that you trust in the room, is going to lead to better outcomes in general. So I love seeing that stuff in a birth plan. When we get into some tricky ones, and the things that I like to tease out with my patients is when we sort of go away from the traditional teaching of labour, and then we really just need to have a conversation about it. So it's things kind of like we talked about. We don't want to have examinations. Another really common one is for, say, induction of labour or augmentation of labour. So induction is when someone's not in labour and we want them to start labour, or augmentation is they've been in labour and then it fizzles out for some reason. Classic would be, say, an epidural. Then we talk about breaking the waters. So what we would call an ARM, or an artificial rupture of the membranes, and that is to sort of stimulate labour. So one of the common things I'm seeing on some birth plans at the moment is, can we break the waters, say it's an induction, can we break the waters in the morning and then leave it for, 6 or 8 hours for that to stimulate birth? And I think where that comes from is breaking the waters is a very strong stimulus for labour. So when someone has broken their waters, we know that 80% of women will labour within 24 hours of that, and 90% of women will labour within 48 hours. The challenge is for someone when it's their first birth, and this is because I get asked this question so much, if it's your first birth, breaking the waters, if you've had no labour leading up to that point, is often not a strong enough stimulus for you to labour in that first 4 to 6 hours. And one of the challenges of doing that, and some of the things we talk about when I have patients who request this, is what does that 4 or 6 hours do to the whole length of your labour? Does that actually increase the chance of a successful labour, or does that really increase the chance of you having a very long labour and being very tired at the end? And if you're very tired at the end, do you then increase the chance of having a caesarean or a forceps or a vacuum? So it can be a little bit counterintuitive. And I guess that's what is really important for me when I see any birth plan, is to say, are any of these things actually potentially going to work against you? And if they are, do you want to think about another option, or at least understand why? If I'm saying, hey, if we break the waters and start the syntocin at the same time, I'm trying to think about your best interest at the same time. So there's so much to take into account. And I actually really like talking about birth plans with people, because I think some of the stuff is, again, it just all comes back down to the why. Well, what is it that you're trying to achieve, and how can we do that together?
And we haven't even talked about maternal assisted caesarean births, have we? That's a whole other topic.
Happy to talk about that. We can do that now or another time. But I love maternal assisted Caesar.
That's lovely. It sounds like you're really helping the woman with her why, and you're helping to support whatever birth she chooses whilst thinking of all the different variables that might happen on the day.
Yeah. Wow, you said that really nicely. That's exactly right. I think, education and trust are the two biggest important things with any birth plan. At the end of the day, if someone hands you a birth plan, you want to know that no matter what's written on that page, if things change, they trust that you're going to make decisions in their best interest. And the way I practice, I feel like that's what I do. That's at least sort of what I strive to do. And in order to do that, I think you need to be able to educate someone to say that, hey, even though it's not what's written on that piece of paper, here's why this is going to be better for you in the short term, medium term, long term. And then I guess the only thing we haven't touched on is when things do change and deviate from a very rigid plan is the importance of debriefing afterwards. And I think that's really, really important. So what I often do, I had a beautiful birth on Sunday, actually, at one of the hospitals I work at, one of my private patients who had quite a strong birth plan, and she achieved a natural birth with a doula. There was a ventouse delivery right at the very end because of, the baby was pretty upset towards the end. And I usually wait a couple of days, let everything sort of settle in. I say to my patients when I see them on the ward each day, I say, look, when you think of the questions, because sometimes it's all a blur of what happens at the end, right? So when you think of the question, like what happened there? Why did we do that? Write them down in your phone. So when I come back on, say, day 3, I have a sit down with the patient. I say, let's go back. Let's start from 8 o'clock the night before you're even in labour. We had dinner, had a good sleep, came in that morning, and then this is all the things that happened. How are you feeling? What happened when we did that? What happened? And by just rehashing all that stuff at a point where you can take it in, and we do it again, later and at 6 weeks and all that kind of stuff as well. But I think feeling like we made decisions in the best interest of mum and of baby, and if we deviated from the birth plan, the whys is really, really important.
Oh, I just love hearing that, because I've spoken about this on different podcast episodes about the debrief after birth plan and after the birth and how it can be so helpful. But I've never heard a doctor say that they do it. So if you're in Sydney, go.
And it's funny because it's amazing because I'll get a series of questions at 3 days, and then I'll see the patient back at 2 weeks or 6 weeks, whereas I've got a whole different set of questions. It's like stuff comes up. I think stuff pops up in your mind and at certain times, and therefore it's really nice and you don't want questions. You don't want things being like, oh God, why did we break the waters again? I don't know that I really wanted that. And then we can sit down and we talk about it again and say, yeah, look, here's what was happening. Here's the reasons why, blah, blah, blah. And I just find that, like anything, if you communicate well with people generally feel much more comfortable about the process and trust that you're there, to help them.
It's all about communication, isn't it? Everything in life.
That's it.
Everything. War, everything. The world would be a better place if we had more communication.
No.
Thank you so much. We got through the whole episode or the whole discussion, the chat before your phone went off. So thank you so much.
Yes, good. Yep. Fantastic. No, that's my pleasure. I appreciate you having me on. It's fantastic.
For those who are in Sydney who want to, or for anyone, how do they come and check you out and see where you're situated and that sort of thing?
Yeah, so I work at 3 different hospitals in Sydney. I work at North Shore Private Hospital, the Mater, and at the Northern Beaches Hospital. I consult out of the Northern Beaches Hospital and out of North Shore Private. But the easiest way to find me is just basically Google my name, Dr. Hugh Porter, or you can jump on Instagram. I've got an Instagram account, so come and check me out there. You can send me a message or get in touch with my rooms through, any way on the internet. It's fine.
Brilliant. Thanks again, Hugh. We'll chat to you soon.
My pleasure. Thank you so much. Cheers.
That's it. So before I sign off, remember my team and I will be putting together the show notes for this episode with all the links, including how to connect with Dr. Hugh Porter at fitnesstomama.com/podcast. Have a fabulous day, everyone, and I look forward to you joining me next week for another episode of the Pregnancy, Birth and Recovery podcast. Thanks for listening to the Fitness to Mama podcast, brought to you by the Fitness Mama freebies found at www.fitnesstomama.com/free.
So please take a few seconds to leave a review, subscribe so you don't miss an episode, and be sure to take a screenshot of this podcast, upload it to your social media, and tag me at FitnessMama so I can give you a shout out too. Until next time, remember, an active pregnancy, confident childbirth, and strong postnatal recovery is something that you deserve. Remember our disclaimer, materials and contents in this podcast are intended as general information only and shouldn't substitute any medical advice, diagnosis or treatment. I'll see you soon.